Stay seated. So our next speaker is Bill Spooner. We heard the individual this morning who he tries to manage, Mike Murphy, the CEO of Sharp. And Bill has been the CIO down at Sharp for 15 of his 30 years down there. And he has accomplished a lot, including helping them win a Malcolm Baldrige Quality Award. I was at the Chime meeting several years ago when Bill was announced to be the John Gall CIO of the Year. So we have somebody of that stature here in Southern California. And I know that, Bill, you've molded a number of your peers in that regard as well. And there's a lot of other things I could say about you, but I'm gonna limit it and let you show us some pictures. Thanks.
It's really a challenge to follow all these smart people. Marty is just brilliant. I've always known that. But then Orlando, he's spending all my taxpayer money in the Palomar Hospital District. Where are you, Orlando? Oh, he left. He didn't even thank me for all the money that I give him. But in any case, it's really great to be here this afternoon. I've been, this is my last year at Sharp, and I said at the beginning of the year that I wasn't going to do any talks. And then somebody asked me to do an ACO presentation in January. And I've done a variation of the same presentation 13 times since then. So this is not going to be an ACO presentation. I couldn't even begin to go into the depth that my boss did this morning. And I'd like to ask you, how would you like to be the CIO negotiating your budget with that man? Just to give you a little bit, I'm going to tell you a little bit about Mike Murphy that he wouldn't have. I'm going to go into it in a little bit more depth, but Mike is a CPA, and he became a CPA after he wrecked his ankle in rookie training camp for the Seattle Seahawks about 30 years ago. And he had to find another career. So he progressed through the CPA ranks. He became a partner at Deloitte. He went to one of our hospitals as the CFO. And then a month after I became CIO 18 years ago, he became the CEO of the organization. And as you can see, he's a pretty knowledgeable, pretty incredible dude, but I'm going to show you a little bit of the other side of him too. In any case, so I'm not going to talk about ACOs. That's a promise. If I can make this go forward. At Sharp, Mike didn't follow this morning, but I always try to do that. At Sharp, it's our custom that we begin a meeting with a reflection, and the reflection is intended to set the tone of the meeting. And I think in this exciting times in healthcare and in IT, we need to live bravely. So I found this a couple of weeks ago. We're here to laugh at the odds and live our lives so well that death will tremble to take us. So just remember that, all of you who are going to be around for another few years, that's really an important characteristic that you have to embody. Mike gave you the overview of Sharp. I won't really add to that except that I've been there longer than he is. I went to Sharp as the CFO of our second hospital, so my background is in finance, although I admit freely that I'm not nearly as sharp in finance as Mike, but it was quite an experience. A few years later, I decided I didn't like fighting over budgets, so I moved over to IT, something that would be a lot more relaxing. But in any case, the talk that Mike did earlier is not the one that he's done as many times as he has spoken about the work that we did over a period of years and have done over a period of years that led us up to the Malcolm Baldrige Award. So I thought I'd tell you just a little bit about it. Here are some pictures from what we call our all-staff assembly. I believe this was the 12th one that we did. And essentially this started as a journey in about 2001 when we said, we did focus groups in the community and said, what do you think about us? And everybody says, well, you're good, but you're not any different than anybody else. And so the organization tried to set forth on a way to somehow distinguish us from Clark and the people at Scripps and the rest of the town. What can we do to be different? And we sort of set this motto that we needed to improve the patient satisfaction, the patient experience by by having more energized staff, more energized employees, more energized physicians, so we really would be most committed to a really good experience and good quality outcomes for our patients. So we went through a real indoctrination. We went all around the country looking at some of the high-profile customer experience programs like Ritz-Carlton. We ended up settling on the Studer Group, which probably many of you have heard of, and we call it Becoming Studerized. But we, for the past 12 years, to really get all of our employees engaged, we bus all employees to the San Diego Convention Center in 3 shifts. It's usually around September, October of the year, for an afternoon or a morning of being rewarded, motivated, energized. And Mike leads that. And the most important thing is that you really have to lead it enthusiastically. You have to embrace it in every way possible. And one of the things that we like to do is to make sure that senior leadership is approachable, and so that the staff walks away, they're really feeling like, we're one of the gang. So Mike does embrace this kind of fully. Now, this isn't the way you saw him this morning, and I wish he'd been here. I had to really work to get these pictures, because when I asked for them initially, nobody would give them to me. Mike has ridden into the convention center on a Segway. We've done some pretty zany things. We did Gangnam Style dancing last year. I don't dance, I was at the back. We did Michael Jackson moonwalk. And I can tell you, you just can't imagine how employees feel you're really listening. But the other thing about Mike, and I don't want to brag about it, and please don't tell him I told you this, but Mike returns every single email. He has an open invitation to any of our 15,000 employees to come and talk with him. And some of my employees have done it. It's kind of interesting because their leader, their manager, will get all uptight. What is he going to say? Mike will call me. Is that person got something up? What's wrong? Why is he coming to see me? So there's anxiety on both sides, but it's really a good experience, and people really appreciate and support Mike as a leader, and it's something that makes it kind of fun to be there, despite the fact that we have somewhat of a demanding load. I kind of like the one in this picture in the upper right best of all, I think, as I look at them. But in any case, that's enough of that. But the one thing I really want to point to is that we've gotten some awards, like many organizations have over the years. We've been on Most Wired many times, and that's kind of a controversial. If you're on the list, you're proud, and if you're not, it must be rigged. But the awards that we are most proud of are really around the employees, and we've achieved not only the Hospitals and Health Networks awards for happy employees, but twice we've been very high on the Computer World 100 list of best places to work in IT. And the part that's neat about that is that you can't rig those. Those are based upon web surveys of your employees. 50% of your employees have to answer this survey saying, what kind of a place to work is this? We actually, I think it was either in 2006 or 2007, were number 3 in the nation of all industries. This year we achieved number 6, and it's kind of neat being in San Diego and being 2 ahead of Qualcomm. And so in terms of a recruitment tool, that's something that we are quite proud of. We can skip the other awards, but in terms of a place to work, we're really quite pleased with that. Connie Chauvin from our HR department is back here smiling. If you want to give her your resume, please do. Commercial, yeah, there she is waving. In any case, so what's up for IT in 2014? This isn't nearly as exciting as Orlando's or Marty's presentation, but it's kind of interesting. 2 weeks ago, John Halamka wrote this article on his blog, and most people know John. He's about the most energetic CIO in the country. He sleeps 3 hours a night. He blogs while he's climbing one-handed up the side of a mountain, and it's like, and he's the only person I've ever known who was willing to go public that his network crashed for 4 days and he actually survived his job over it. But in this article, he's basically saying that I've been popular for all of these years because I produce all these wonderful technologies. I'll do a favor, I'll build a system for a group of constituents, and they love me. And this is going to come crashing down on me this year because I don't have any bandwidth. I've got to do ICD-10, I've got to do Meaningful Use Stage 2, I've got to do whatever's going to hit me with HIPAA, and then there's the Affordable Care Act and whatever that manifests itself. And so I'm going to lose my popularity over the next year. I'm sorry, but I won't lose my job. you aren't going to like me, but I'll still be here. So, you know, so I found that to be really kind of interesting, and I'm wondering whether John really believes that, and he's just trying to hedge his bet so everybody will say he's a hero at the end of the year, or whether it is really serious. And I was on a panel with Tim, sitting here a few months ago, when Tim said, you know, we're talking about what projects we will put on hold if we have to, right, Tim? And, you know, in my organization, we haven't talked about that. It's like full steam ahead. And so it's just a question of where you place your bets. But in any case, there's just no question that 2014 is going to be a bit of a challenge for us. We just don't know how big it is. But we are plugging along at Sharp, and we have some things besides all of the regulatory reform. Mike mentioned this morning that we are one of the providers under Covered California for San Diego County, and there's been a little bit of infrastructure work to build that out and to be ready to accept enrollments as of October 1, and we were ready. But, you know, a lot of work that will progress through the year. We've got a bunch of ongoing initiatives. I'm not going to outline them all, but around expanding our clinical documentation and rolling out more modules of Cerner. And Mike mentioned, I'm going to take a little bit different, but he mentioned two of the things that are on my mind. We're trying to really rethink our patient portal approach so that it can be more all-encompassing and we can take it past the first generation. And that's going to take us some work because we really feel we've got to have our patients engaged, and we really want to be the slickest provider in town in terms of our portal, and those guys at Scripps, wherever they are, they're catching up with us, so we got to keep going. And we're talking about new ways of organizing our physicians because there's concern about retiring primary care physicians and how are we going to replenish them. And Mike mentioned data governance. We had our IT committee meeting yesterday and managed to make a plug there just so that the IT committee would prod us along too. So Mike was paying attention to that, and I do appreciate it. But the whole BI strategy around getting our data governance is a real big deal for us. I likened it in our description yesterday to driving down the road with my car with 4 different size tires on it and wondering why it's kind of wobbly. But in any case, and then we're going to break in a new CIO, and that's the best part on the agenda that I like because, oh God, I don't want to have to do all of this. I didn't bring my iPhone up here, but I have an app to tell me how many more days I have before I can bail out on it. I'll show it to you later, and it's like 200 days less than the deadline for ICD-10, so it's really good. So what's next in the world? You know, Mike keeps telling people I'm retiring, and I say I'm retiring from Sharp because I'm looking around for things to do to keep myself busy, whatever it is, come around maybe trying to work for a vendor and getting all you guys to listen to me and buy stuff or whatever. But so I'm trying to figure out what's going on in the industry, and you know, what are the things that we should look forward to. And realistically, our future in IT is based upon what happens to the care model and what happens to the payment model. We can cut to the chase on all of that. It's really how are we taking care of our patients and how are we going to get paid for it, and along with there's the shrinking amount that we're getting paid for it. So thanks to Scott Joslin, I read the Harvard Business Review article last month, and he may have sent this to some others in the room, just an incredible article by Michael Porter with just one model in terms of what this Harvard professor thinks the healthcare model ought to look like. And it's really pretty compelling. If you haven't read it, you really should. What is interesting to me is that I walked into an internal strategic planning meeting a few days ago, and there were 3 other people from our leadership team who also had the article. So, I mean, very clearly we're looking at that, and people are trying to understand, you know, what's healthcare going to look like? You know, we all know that it's going from pay for service to pay for value, but how is that really going to happen? And, you know, and value means outcomes. So they've created this six-step model that ends in step number 6, meaning an underlying IT program. But there are a lot of things, and I'm not going to go through all 6 of them, but there are a lot of things in there that are going to be a heck of a lot tougher than the IT component that we have to be thinking about. Step number 1 is this concept called integrated practice units. And an integrated practice units means that for whatever your condition, it's one-stop shopping. There's a care coordinator, and you're not going to be sent from primary to specialist to physical therapy to whatever. It's going to be one integrated care unit that is going to make sure that your care is monitored, and they're going to know everything that's going on with you, and then you're going to report your outcomes. The other part of it, which I found is kind of interesting, which challenges all of us, and Marty talked about the integrated delivery networks being the winners in the future, and I think that is true, but the thing that they point out in this model is that the integrated delivery network is not like the things that we have today. I replayed a quote that's really probably applicable to mine. I know it's applicable to my organization, but probably is to most of us, and that is that our IDNs today are a collection of individual hospitals with duplicate services. But if as we look forward, they really believe that we need orthopedic specialists, we need cardiac specialists. We can't expect to provide the best and the most economical care if everybody does everything and it's just sort of status quo, and we're not really pressing for the most effective and the most efficient care. And so when I think about the IT component, it's like, who knows how this is going to evolve, but that's really the tough work, because that's the change in our culture, change in our organization. There's going to be some winners and unfortunately some people who feel that they're losers out of that. Yet there's all sorts of IT implications that will come along should this model evolve. And they listed a half a dozen things in the article, and I dreamed up a few more things that are really threatening or to potentially impact us, or definitely will impact us with on the IT side. And so I've got a laundry list of 8 or 10 items, but there are some that I think are a little bit more significant than the others. And there's the focus on the patient. I mean, today we're provider-centric. I worry about what the doctor thinks about the system. I don't worry about what the patient thinks about my system. And, I actually, Marty, I actually voted for social media too, because I'm convinced that that's the answer. And our focus has to change from provider to patient if we really think that we're going to provide the best care and get the patients engaged. So the patient has to be the focus of the care. Patients are going to report outcomes. There's this whole concept that, for one thing, there's a group that's formed to create universal definitions for outcomes, and then move from, you saw those lists of reporting indicators that Mike showed this morning. So many of those are process indicators and the expectation that these are going to change to real outcomes. How did the patient's health change? What did they think about being in the hospital for 3 days and going home? What was the care like for them? How did their health condition improve? And so that means that we're going to have to collect that data from the patient, and somehow it's got to go into our records. Today, it's our record. In the future, the expectation is patient-generated information from their chiropractor visit and other external services, as well as what the patients think of us, will go into it. So, that's really a big deal when you think about it from an IT perspective, and I don't believe that, I would guess that probably none of our systems would really handle that today. Some of our vendors are starting to go there, but I think we've got a lot of work to achieve before we get there. There's this other concept called time-driven activity-based costing. I used to be an accountant, and I never heard of that term until I read the article. I Googled it and found out that the concept has been around since 1993 or 94, a totally different approach to much more detailed patient-focused or outcome-focused cost accounting. Somebody will have to figure that out in the next few years, but that's not going to be me. There's a lot written. You can go out on Google and learn all about it. Another Harvard professor dreamed that idea up, and they've really been pushing, and the belief is that in order to better understand the cost of care, we have to figure it out. I hope our EPSI system that we just finished installing last year will support it. And the revenue cycle. Today we've been doing all sorts of different kinds of you could call them bundled payments, contract services. Mike mentioned the capitated business that we have. In a lot of cases, though, that's going to change to the point that it becomes the dominant model, and the way that we have been able to, I'm going to say, adapt our systems in the past, I don't think will be an efficient way of processing. I think we'll be doing a lot of work going forward in terms of the whole revenue cycle so that we can really have efficient processing of the patient transaction so that we can really effectively and efficiently bill whoever the payer is for the patient care. So anyway, moving along, there's another paper. I didn't get this one from Scott. I forget where I stole that one from. And this was a McKinsey paper a few months ago, and they call it the $1 trillion prize. And their concept is that if by 2018 we could get to 50% outcomes-based payment, we could save $1 trillion over the next decade. You know, pretty simple, except that we have to get there. And they share a lot of the ideas of the Porter article, and I'd be glad to share that with somebody if they wanted to distribute the article, but it is pretty interesting. But so they took a whole different cut on the care model. They divided all caregivers into 3 categories. If you can be a component provider, that would be like an X-ray or a lab service. You can be a healer. That's somebody who takes care of me when I have an acute episode, and you can be the partner. The partner would be my primary care, my ongoing care manager. And you have to pay me differently based upon the category of provider that I am. If I'm a component provider, it's fee-for-service with quality indicators. If I'm a healer, it's a bundled episodic payment with quality outcomes. If I am a partner, you pay me based upon capitation, essentially. And so the whole model has to be able to reflect that in a convenient way. And I'm not going to really, you can read the article to get their opinion on you know, the whole model and how the incentives have to be altered in order to be effective. The thing that I really saw, though, in this model, and it caught me by surprise. I had to read about 2/3 of the way through before I realized that this was being written for the payer space. It was not being written to their provider customers. And I thought, well, this is fantastic, because we really need to know what the kind of advice the payers are getting about future payment models. So there were a couple things that I got from it. One, McKinsey had a really more gradual transition. Porter says, here's the end state. McKinsey said, no, based upon what your providers have today, here's where you should go. So in the future, they think it should be a risk-based bundled payment. McKinsey says, well, the providers' billing systems can't handle that at all, so do a retrospective, quality-based system so that everybody sends in their bills, and then if they're over or under, you do adjustments and you do quality adjustments. Do that to start with before they can get geared up. So it was pretty interesting to read, but it really did emphasize to me what I think everybody who's been avoiding making changes to their revenue systems over the past several years, get ready and have a good time. So I'm going to switch gears a little bit. I've been on the board of the National eHealth Collaborative for a few years, and that was something that I joined because I thought, well, going forward, I'll be bowing out of chime when I'm no longer a CIO, and it's kind of fun to get out with people besides CIOs because we all commiserate, and so it's kind of fun to listen to what everybody else thinks about the future of healthcare. And I learned a couple of things hearing from a broad dimension of stakeholders. And the most interesting thing, of course, is that the patients hate us. And so I took out the wrong kidney. What's the problem? But patients really have expectations, and interestingly, vendors who sell things that relate to patient expectations tend to reinforce them. But it's kind of interesting. It isn't just vendors. Consumers' unions will point out our flaws. The privacy rights groups point out our flaws. Well, about a year ago, maybe it was 2 years ago now, the eHealth Collaborative published this framework, as they call it, for progressive patient engagement. And this is a great guide for anyone who's trying to build out their patient portal strategy. It's sort of start with the beginning, educational material, some basic online functions. Sooner or later, you start loading in patient-generated information. You get disease-specific educational material. It's a really neat thing for anybody who's working on their portal strategy to consider, because it really does make sense. And if you're doing a commercial approach, many of the commercial vendors are looking at this anyway, so you're going to see them rolling it out in a fashion somewhat like this. There are some other frameworks, but as I've talked with people, they really find that this one is the one that makes more sense to them. But that's only a start. And Kara and I got talking about this a few months ago when we were on the same panel as Tim, actually. And she has been using this extensively over at Methodist, but I surprised her this morning when I told her the next generation. Well, our friends at Deloitte with nothing else to do, published this report a while ago about consumer segmentation. And they said, well, you can't consider that a patient is a patient as a patient because we all have different needs based upon where we are in a care cycle or in our life cycle. And so this is being blown up, and it's just being kicked off now into this thing that's going to be called the patient experience framework. And the whole theme around that is that we expect something different based upon what they're calling our persona. So if I'm a chronically ill patient, for example, I've got more needs to interact with my health system. If I'm old and in my declining years of life, that's a little bit different approach. If I am raising a young family, I've got different expectations of the health system. So they've kicked off this effort just in the past month to try to basically recreate this framework, but looking at each one of those personas. And so they've created this map with the persona, what motivates people in that category as a patient. Across the top are the same categories as the engagement framework. Down the row, what I'm doing, thinking, feeling, etc. And in the intent to build out this whole thing with really a view to how do I engage with the health system? How do I engage with my medical record? Because that may be different because my record spans more than the individual health system. How do I deal with my individual provider? How do I get my health education? So over the next year, they intend to build this out. It's going to be kind of interesting with what they do with it. They've gotten some good traction on the basic framework, but I think it's something we're all going to want to look at, think about. So now I got the information from all the smart people, and I'm moving right along into the not as smart stuff. But it's kind of interesting. I created this model. You can see this is not as pretty a graph, but I created this model from, Orlando called it ideation, I called it imagination. And how do I get from an idea to actually having that idea change healthcare? And it seems like to me, and you could create other models, but in this stair-step process, I think of an idea, and then I turn it into something innovative. And Orlando showed lots of examples this morning. So then I got to figure out how to put all that stuff into my legacy healthcare. How do I integrate it with my systems? How do I integrate it with my process? And I think both of them are equally challenging. I've got to get people to change. Orlando described some of the challenges in getting people to change, and we all know the challenges in terms of how we get XYZ device, module, you name it, integrated into Cerner, Epic, Meditech, you name it, and not a small task. And then once I get it done, how do I get people to use it? And then ultimately, how does that result in transforming healthcare? So, has anybody in the room besides me been to TEDMed? Few people have been to TEDMed? No? Well, I had the opportunity. You did. I had the opportunity to go this year, and I walked out of there saying that's something that every CIO should be required to do once, because we have to understand how these totally imaginative, creative people how we can relate to them and how we can help them determine which of their ideas are good ideas and which are not, and how do we bring them to reality. I mean, the stuff that Orlando was talking about this morning, it's 12 minutes at a pop for 3 days, and people with some of them, you'd say totally crazy ideas, some of them really fantastic ideas. Some woman PhD researcher said, the NIH doesn't look favorably upon women grant applicants. And I needed money, so I went out and did a crowdfunding thing on the web, and I got my $1 million without the NIH. Yeah, pretty darn creative. And that was just kind of one of the clever ones, I thought, but a lot of them were things like Orlando was talking about, or just different models of healthcare, and somehow we have to learn to relate to that. So that's sort of one piece of this whole cycle. And then some of us who've been involved in public policy, working with ONC and Dr. Mastashari would say, well, as soon as Farzad thinks up the idea, he thinks that we can actually change healthcare with it, and there aren't any steps in between. And he's left a long legacy. I was in a meeting with Jacob Reiter last week, and he talked about how us slow CIOs are still working with the certified EHR 2011 version, and they're working on 2016, and why haven't we caught up with them? Okay, so those are the things that we have to look to, and we have to try to understand how that we can reconcile our views with them and really continue to move along healthcare. And then, this is really our challenge, and I already talked about it. How do we really find the best ways of bridging this gap so that we can bring innovation quickly into healthcare transformation? The physicians for the longest time have cited this literature that says it takes 16 years for a new medical practice to become commonly used. And I don't know whether that's right, wrong, or indifferent, but as I look in some of the things in my own organization, I mean, maybe not 16 years, but it's more than 6 months in terms of getting physicians to do documentation, to run standard order sets, to do CPOE, et cetera. And I think the winners among us are going to be those that find whatever kind of solution there is. I don't think it's magic. I wish it were. But the winners among us are going to figure out how to shorten that cycle in different ways. And maybe a think tank with Orlando, or people who really are trying to engage with us in terms of mainstream healthcare IT can help us along that path. Anyway, moving along. So what are my thoughts? And I'm going to finish up a little bit early. This is good. But so business intelligence. Who in the room thinks they've got their BI strategy totally wired? Come on, raise your hands. As I talk with folks, it seems like we all have a different approach. I've got it, Mike mentioned this morning, we have a fairly sizable data warehouse that we began about 20 years ago, and we do everything under the sun. We've bought some commercial products like Crimson and Medventive, and as soon as we start to implement it, we realize that it doesn't really fit our data model, and we don't really want to kind of standardize in the way they expect us to be standardized. But I think many of us are using multiple tools or hybrid tools. Does anybody have as many as 5 VI products? Come on, admit it if you do. Tim, come on. This is like, confession. Anybody else want to confess? How about 4? Oh, this is kind of, you guys are pretty easy. I mean, I've been in a couple of meetings where one person had 7 different BI products, and none of them talk to each other, of course. I think I've got 5 at least, and plus our data warehouse. And I read a lot of the information that comes from the advisory board, and it's pretty thoughtful. I really appreciate the work that they've done, and I think the best advice from the advisory board on our BI strategy is that we shouldn't make long-term investments because there's just so much work going on that we're going to be swapping out, changing strategies, changing products. Vendors are being bought. Startups are not going to make it. It's really incredible out in the vendor community these days. We haven't done much in terms of big data other than talk about it. We keep saying, let's figure out little data before we move on to big data. But, a huge issue for us. The whole continuum of care, if you go back to the Porter article, I think that we're going to have to get more well integrated across the continuum of care. We've done a good job from an analytics standpoint. We can pull all the data in from lots of different providers and analyze it retrospectively. But some of the advanced thought is that when you think about independent practice units, I've got to be able to fluidly move the patient to wherever they need to go to get their care. And I think care management is going to be a big deal. There was an announcement just yesterday, I think, or the day before, about the advisory board buying a software product that is totally care management workflow. I've got a little slide of Evolent, which is trying to do the same thing around a data warehouse. And I think that's an area that we're going to have to approach. And if we're really trying to be the most, have the best outcomes, be the most efficient, we're going to have to be able to move our patients with the least barriers from point to point, and minimize the anxiety of the handoff. HIE has a part in it. I'm not sure what the part is. Every time I go into a group, who thinks HIE is dead? Get them in smaller groups, and people are saying HIEs are dead, but then I have my own, and that's the way we are. In San Diego, I've got my own that I'm implementing. Scripps has their own, but we're trying to slowly but surely get the community HIE in place. We're not really sure what we're going to expect them to do versus what we will do internally. But when we start thinking about transparent workflow, efficient workflow, it has to have a role there somewhere. and sort of this concept that I've been playing around with in my 13 different presentations. Oh, is there a starter set to support an HIE? Can I identify a half a dozen things that really every HIE should have as you're looking around the country? They're all doing something similar, variations, but is there sort of a standard model starter set? So this is, I stole this slide from Evelyn, and I think it's really fascinating in that they really do have the patient at the center. And in so many of the vendor representations, no offense to all of you vendors, but the vendors say that they're doing it, but as you go into a little bit more depth with Evelyn, it does seem that they're trying to really have this patient-centric model around a database so that you can hand off the patient. It's pretty intriguing product for me. It's probably the only one that I'm really interested in digging in a little bit more deeply right now, because it's just kind of a pretty advanced idea. So, moving along, I think I've said it all. It's going to be care transformation, and everything we do is what happens to the care model and how we get paid for it. The whole issue of patient-generated information, I want to go back to TEDMed a bit. At the CHIME meeting, the Wednesday evening dinner, I attended a dinner where the curator of TEDMed, Jay Walker, spoke, and he had some interesting conversation. He was right with Marty. Social media is really the key. Everybody under the age of 30 has a device, and they do everything under the sun on their smart device. They use various kinds of applications, and if we're going to provide them health care, we're going to have to work the way they work, and so we just better get used to it. Another interesting thing that he had to say was, and those people don't really care about privacy. I mean, my security and privacy people were turned over hearing that, but basically, hey, they're exposing their whole lives out on Facebook. Well, sooner or later, we're going to have this change, and people are going to just say, it's not all that big of a deal, and we'll see how that comes forward, because we know the other side of the argument. But as more of these younger people age, there may be some shifting in it. And sort of the third thing about how we change healthcare, which I thought was really kind of interesting, is that his perspective is that as providers, we're not going to change patient behavior. My physician can tell me to stop smoking if I smoke, but I don't do it. I just keep doing what I want to. They should tell me I shouldn't drink my 3 glasses of beer on Friday night or whatever, but I'm not going to do it. But his position is that marketing people are going to change patient behavior. And that when the marketing people realize that they can make more money changing patient behavior than supporting the status quo, they will do it. And people were sort of teeing it, and he goes, so who would believe that you could have scraped off the stuff from the bottom of the rendering plant and boiled it up and added some coloring to it, and women would put it on their lips? And that came from marketing. So, I mean, his position is, look a little bit beyond the traditional provider network. Look at how you market your services and market what you're trying to accomplish. And obviously, all of us are going to be facing tighter budgets, do more with less. The one thing that I wish I had done many, many years ago, and I mean, some of you probably have done it a lot better than I am. Anybody in here a member of SIM, Society for Information Management? One. And probably recently, because Paul was such an advocate. I know of a handful of CIOs who are a member of SIM, and it's because it's cross-industry, and there's so much that we can learn from other industries. And I've started in the past few years going to things like Cisco's generic conferences and things like that. There's so much that we can learn from these people that, they've got bigger budgets to do piloting, so we can learn faster about what's worked and what hasn't worked for them. We can learn to gut it out because they've had tighter budgets than we have. When their revenue shrinks, their budgets shrink. And they're just a pile of lessons that we can have from them, and I found that just as a really valuable lesson. And obviously, we just have to be able to scramble. This is going to be a really creative time. So this is my last slide, and I'm way ahead of time. I love it. One of my staff brought this slide to me. This is one of these things from the 70s from somebody who was out on drugs or something, I think. But But it's like, you know, we have this working process in healthcare. We're trying, and it's healthcare and technology, and some of the pieces are coming together very nicely, we think, and then there are other things that appear to be going backwards. But ultimately, you know, we're looking for this future state where it doesn't cost so much, it's a lot better, and patients are a lot happier than they are today. I will be glad to take questions. Okay.